Dear colleagues, willkommen, schön, dass ihr zugeschaltet habt. We would love to welcome Professor Ge from Shanghai in China. Willkommen, Professor Ge.
Hallo, guten Tag.
Professor Ge hat mehrere Jahre in Deutschland verbracht, war in Mainz und in Essen als Oberarzt. Wir würden das weitere Gespräch auf Englisch weiterführen. Aber wenn ihr Fragen habt, ist das gerne natürlich auf Deutsch und auf Englisch beides möglich. Professor Ge is the chief of cardiology of the cardiology department at the Zhongshan University in Fudan, at the Fudan University in Shanghai. He is the chief of the Shanghai Cardiovascular Clinical Center, chairman of the Shanghai Institute of Cardiovascular Diseases, the head of the Institute of Biomedical Sciences, and at the moment he is the president of the Chinese Society for Cardiovascular Physicians and the past president of the Chinese Society for Cardiology. So thank you very much. You're involved at the advisory board of the ACC of the American College of Cardiology and both involved in the European Society of Cardiology too. So a lot of obligations you have. Thank you very much that you spent your time for us young cardiologists and young doctors who would love to learn from your experience regarding the context of COVID-19 and the exchanges we have at the moment.
So hello, guten Tag, labor colleagues. And actually, thank you very much for Dr. Hashmi for the invitation. Actually, you may know that I spent nearly 10 years in Germany. That I said, you always say that Teil von meinem Herz bleibt immer noch in Deutschland. While I was trained in Germany, I learned my intervention skills from my chief, Raimund Erbel, and Professor Junbo in Mainz, and afterwards in Essen. And yeah, since I was called as chief of cardiology in Uniclinic Shanghai since 20 years, and after 20 years of building, when I was called as the chief of cardiology, we have only 88 bed for cardiology and 40 bed for cardiac surgery. Because we are a center together, but after nearly last 20 years, I built really one of the biggest center in China. We have 350 bed for cardiology and 150 bed for cardiac surgery, and we have another 41 bed for the ICU after operation. The patient belongs to cardiac surgery, and we have 29 bed for the CCU that for belongs to cardiology. We have an extra the polyclinic, and yeah, we really warmly welcome you all. You after this epidemic to visit my center, and I have two doctoranden aus Deutschland auch. They're working here, and yeah, we can have a very good relationship if anyone want to visit Shanghai. Yeah, since the outbreak of this epidemic, the COVID-19, and in the middle part of China, in Wuhan, and actually in the beginning, we frankly to see the whole country was not prepared. You know, the people who had fever, normally they have a polyclinic to in charge of the fever patient. The patient, suddenly we have 100 of patients, but each hospital only have about maximum of about 30 bed to host this patient. We have 100 of patients. All the hospital they do not know how to do and what to do, and we do not know how to handle such a huge amount of patient. And afterwards, and by the government, we send 42,000 medical personnel. Of all this 42,000 medical personnel, 28,000 were nurses, because we do believe that people they need to be taken care of. Then we build we take the auditorium for the athletes auditorium to host all the patient which is not in severe or critical case. And we enroll the patient to several separate hospitals for the severe case. And at the beginning, actually, this was because it was just the holidays or vacation of the Chinese New Year. And we have the people, in China, they would love to visit for the New Year, stay with the whole family member together. And, all the trains, flight was full. And this, I think, worsened the transmission of this infection. And by the beginning of the new year, and the government said we have to really control close the whole city. Therefore, we blocked the highway, we stopped all the airlines, and we built the local hospitals, and we sent the whole 42,000 medical personnel to help them. And since then, this situation was becoming better, and all the patients with fever get totally monitored, and we have to take the swabs to get a nucleic acid tested. But at the beginning, if the virus do not catch, and the positive result normally, the sensitivity is about 30 to 50%. A lot of people, they are infected, but not get positive nucleic acid. And therefore, we have several groups developed the antibody. This antibody is against the spike, the glutoprotein on the surface of this virus. And my group also, we investigated, we produced one kit, IgM and IgG. For the IgM, during the first week, normally 3 to 5 days, it will become positive. And afterwards, on the second week, IgG get elevated. We put these two together. The sensitivity and the specificity is over 98%. And therefore, with this kit, you are easily to screen all the cases. But we had also difficult time. At the beginning, no one knows how to handle this patient. And in early the post-mortem study, we do find that very gel-like secretions in the lungs, and this block the exchange of the air, and the patient, they get really hypoxemia, and the other system are normal, and in the severe and critical ill patient or group, it's only about 20%. The other 80% are very mild, even only cough, no fever, and this belongs to the 80%. We put the patient in the auditorium, and the 22% with severe and critical case, and we admitted them to the ICU. What I want to give you the advice, I think is very, very important, is first to protect yourself, everyone, no exception, no matter healthy individuals or patient. You wear the mask, especially you call it in Europe PP2, or we call it N95. This surgical mask to protect the virus getting in. And secondly, you have to really, because this virus gets also contact infection, you have to wash your hands, and better do not have meetings, collections, and parties together. This is very, very important. You see now the situation in the US and in Europe, why you have the most of your patients are young patients, because the young patients, they are love to go out to the bar, to drinking beers and so on. This is very dangerous, especially for because you don't know who are infected. This is very, very important. You have to be, I saw from the news that people do not like to wear a mask. If anyone wear the face mask, they do not like, because you believe the people, they are ill, they wear the mask. I think this situation it's best in Japan, because in Japan, a lot of people, they have allergy. No matter who are normal, the healthy people or ill, sick patient, they all wear masks. Therefore, you know, the situation in Japan is really very minor. I think this is very important to wash your hands, to protect yourself with masks, to avoid gathering together with the parties. And this is the key. Secondly, I think for the very sick patient, we call severe and the critically ill patient, you have to use, because this patient gets hypoxemia very frequently. They get pain. They are not able to breathe. And I think you have to really get the ventilator. But for the critically ill patient, ventilator will not help. You know why? We do see the patient, they breathe very fast, but the air do not get to the lung. They're only in the tract. And I think in this kind of situation, ECMO is very helpful, because you have the ECMO to make the saturation of the blood, and the blood, venous blood come out and through ECMO and come back to the superior vena cava. And this will replace or partly replace the lung when the lung gets failure, and let the patient aware and to cough out all the secretions, because the secretion like a gel. And because we do not, up to now, we do not have specific treatment or drugs for this virus, we let the patient to recover by themselves. Normally, a week after, the patient themselves, they build their immune system, and that it will come better and better. This is very important. I think another thing is I want to say is we do see patient with fulminant myocarditis. That means the virus could attack myocardium by itself, but this is not very often. We only see very rare cases. The patient has this COVID-19 and also decreased ejection fraction, and the patient will, if you using ECMO and using the supportive treatment, and the patient will recover a week, and the ejection fraction will recover to about more than 60%. We see the patient, the ejection fraction reduced to 20% only, but after this acute phase, it will normalize. And because this virus could induce, we call inflammatory storm, and we do see the elevation of CRP, the elevation of D-dimer, the elevation of interleukin 6, interleukin 8. We do see the patient, to our experience, about nearly half of 40%, 44%, the patient with elevation of troponin, but not very high, except the fulminant myocarditis. Only very rare, the troponin elevated to about 7,000, 8,000, something like that. And this myocardium will not contract. You have to really handle with very care. But nearly half of patients, they have a minor elevated troponin I or troponin T, and this indicate injury of a myocardium, but it's not the main problem. The main problem is because of the inflammatory storm. In our center, we treated 11 cases with the antibody of interleukin 6. If the interleukin 6 was elevated, CRP elevated, and it is effective. When the interleukin 6 was not elevated, maybe it's no use. Therefore, the antibody produced by Roche, it is effective to the patient with the inflammatory storm. And what I can tell, I think, or the experience is, can be summarized as above. And if you have any questions, I would love to discuss with you.
Thank you very, very much. to understand the last point you made, that interleukin-6 antibodies have helped in patients where interleukin-6 was elevated. So would you say that patients with, so in my imagination, very simple, I would say that patients who have high levels of interleukin-6, they are sicker than those with lower levels of interleukin-6. Would you say that these patients, if they're treated, have a better outcome than those who have low levels?
We see the patient nearly all with elevated of D-dimer, but this means the patient maybe develop microembolization or microembolism first. Secondly, elevation of CRP, nearly all. But when it is only lightly elevated, maybe it is not useful using this antibody, but the patient with elevated interleukin-6, interleukin-8, we can use this interleukin-6 antibody, and this patient will inhibit the inflammatory.
Very good.
This drug called tolizumab, this antibody.
I wrote down a few questions which came into my mind, but I would start with the questions the colleagues wrote as well in the YouTube comments, as well as in the WhatsApp group we have created for this. So the first question by Mr. Friedrich is, young males are generally at higher risk for acute myocarditis, while in men above 50 years, acute myocardial injury is more likely ischemic. Did you observe this too?
What we do see that the elderly, the mortality is higher, and also the late outcome is worse. We analyze the why this elderly they're getting worse outcome. We analyze, for example, elderly people, they have normally multi-organ disease, and they might probably have the ischemic heart disease. Because the patient has hypoxemia, if in the normal condition situation, this ischemia will not play an important role. But in the severe hypoxemia, and only, for example, moderate stenosis of the coronary artery will induce severe ischemia. Therefore, we do see, I saw a patient, he was 67 years old gentleman. He got a myocardial infarction, inferior myocardial infarction during this infection. Well, what we do believe is might be complicated. What we do believe is because the patient might probably have the stenosis, and in the normal situation, this stenosis will not getting myocardial necrosis. But if you have the condition of hypoxemia, and you use the ventilator, it will not improve. I think this will induce severe ischemia. Therefore, I think this explains why with the patient died nearly always elderly. But we do see the patient, for example, our colleagues, he died on his 29 years old. We have one colleague died at 34. And all of this younger patient, they have a huge elevated inflammatory factors, CRP of several hundred, and interleukin-6, interleukin-8, and so on. I think in the younger patient, if they died, it's because of this inflammatory storm.
Thank you. Dr. Stressler asks, some COVID patients also seem to present with gastrointestinal symptoms. Did you develop a screening strategy for these patients?
We do not see very frequently, but I think this is possible because you know that this virus infect the cell. It should be through this ECE2, this receptor, or this you can call receptor. And this receptor normally is very frequently on the endothelial cell, in the renal, and so on. And I think the patient might probably, you have the virus could get to the cells through that way, but we do not see very frequently with gastrointestinal disorder.
Mm-hmm. You told us, as the experience of other colleagues are also, the ECMO is one of the techniques we need very much in these patients with severe diseases. So we prepare ourselves in Germany, and so big centers have the ECMO technique, and that's very frequent. But the smaller the hospital is, the less frequent is the use of ECMO. And
right.
How did you do it in China? How can you give the expertise in having ECMO to the sites which are affected?
Sure. Actually, in the early phase, our mortality was high, and in the second phase, and we found this main problem because of this respiratory failure, and this respiratory failure, even though you're using the invasive ventilator, it's not proved, because as I described, the air only gets to the upper respiratory tract, not to get to the lung. And this leading to the hypoxemia. And the ECMO, especially the VV mode, and it drainages the blood from the inferior vena cava and to saturate and give it back to the superior vena cava. If the heart function is okay, this will certainly help, but you should have to use this earlier before the patient gets multi-organ failure. If the patient gets multi-organ failure, it's no use. But only before they get multi-organ failure, and you can have this blood to help the patient, the lung function. And of course, we have the several cases using the VV and VA mode. That means the patient, if they have the left ventricular dysfunction, and we using VV and VA mode, try to send the blood back to the artery system. I think this is too complicated, because in the CCU, I don't know the situation. You have really, I give you the advice, please, and you have to wear normally 4 gloves, 1, 2nd, 3rd, and doing ECMO we use the 4th, and by using 4 gloves and by the implant the ECMO is extremely difficult, and therefore for any manipulation it's difficult, and therefore I think only in ICU you can use this for the severely ill case. Oh, one thing I have to really remind you, please, if you enter the ICU, you have to cover with the glasses, the face mask, not the mask, to cover the whole face with the glasses. And we did a test. We used the swabs in the ICU, 3 hours. You will find the virus, because in the ICU, the huge density of the virus. There were 1 cough. They tested 1 cough will be 1 million virus, and if you have the mouthwash, and it's about billions of virus. Therefore, the patient, you contact the patient cough, and the whole air was filled with the virus. You have to really to protect yourself to be avoid getting infected. Therefore, if you ask the ECMO only for the severely or critical ill patient using ECMO before they get multi-organ failure. And you remind the patient with the this position to get more, not lie on supine, and to on bow to get more oxygen to the lung.
Did you send doctors with experience in ECMO to the affected areas, or have you had, telephone conferencing? How did you talk to users? I imagine not all physicians treating COVID patients have this high-skilled experience and skills. Huh?
The ECMO was used on the second phase. Actually, at the beginning, we do not know how to handle this kind of patient. And afterwards, we purchased a lot of ECMOs, and we sent normally the ECMO in the clinical practice is in the ICU and our surgical department, cardiac surgery. And in the Department of Cardiology, normally we do not use the ECMO. If we need, we will call our surgeons to help. But this time, and we send our cardiologists together with the cardiac surgeons. For example, I have 2 fellows working in the ICU, and he implanted 5 ECMOs, all the cases, and went well. And last week we had a communication with the ACC governors, and we have more than 10,000 colleagues on the website, and we show the case. The patient after ECMO, they can get really recover well. And now in the ICU or CCU, we call CCU, our cardiologists, they could master this technique. The technique itself is not so very complicated. Only you have to really have the one catheter in the superior vena cava, one catheter in the you can in the femoral, or in the you put in the inferior vena cava and take the blood out, get ECMO, and give blood back.
And with patients with levels of troponin, I know that you have very high experiences in coronary care. So when would you think about doing a cath in these patients? And what are your recommendations regarding this?
Our society, we published the consensus. And this consensus I can send to you. We have an English version. We do not recommend patient to the cath lab unless we are very sure the patient has a myocardial infarction, which is not stabilized by thrombolysis. We are in Chinese. We summarize 20 words or the 5 items. First, to deliver the patients to the nearest center as short as possible. Secondly, the patient gets to the what we call a call center. The center should have cath lab, but the cath lab should be on the negative pressure. Otherwise, if you really want to do the cath, you have to shut all the air conditioning, especially the central air conditioner. This is very essential. Otherwise, you will infect the whole system. This should be disaster. You have to shut off the central air conditioner. Third, we restrict in the cath lab 1 nurse, 1 operator, and to really restrict people getting in, because the material will be also get infected otherwise. And fourthly, we encourage remote consultation. For example, they call me, and now in China the 5G is very fast. We can switch on to see very clearly what should be handled on. We give our ideas. And lastly, also very important, if no contraindication, we will really encourage you using thrombolysis, not to deliver the patient to the cath lab, because you have to take care of the other patient. If you affected the system, and the other patient also lost their chance. And only if the patient hemodynamic is not stable, you have to deliver this patient to the cath lab, and you have to follow the rules as I told.
These were, I think, very, very helpful recommendations. Thank you very much. Mr. Niendorf asked, thanks for your first-hand report. This is very helpful. Is there increased risk for patients with hypertension and ACE inhibitors for COVID-19 infection and the disease severity?
Sure. This question, I think, is very intensively discussed on the internet. And my fellow, he wrote as a comment published. Actually, at the beginning, we thought it would be. Why? Because, as I mentioned, the virus combined the ECE2 to the cell, and in the cell to get reproduced. Theoretically, when using ECE, especially ECI, not ARB, and the reproduction of the ECE2 will be elevated, and it will theoretically enhance enhance the infection of this virus. But up to now, we do not see any evidence that using ACI or stopping ACI or stopping ACI with bring any benefit. Therefore, we give the recommendation: do not stop ACI. It's not necessarily. We do not have any evidence to stop this.
Thank you very much. A note by Professor Burkert-Pieske, who thanks you for this great interview. Thank you, and hi to Professor Pieske. He asked, when does the viral phase end and the hyperinflammatory response prevail? How can you dissect these different phases in the disease course?
It's not possible. So vielen Dank, first of all, Professor Pieske. And we do not have the capacity now to identify this actually.
Okay. So we have patients with, very sick patient courses. They have multi-organ damages, so they would need renal replacement therapy. And one of the questions by Dr. Hohendanner is regarding this renal replacement therapy is, do you have any experience on cytosorbs or other forms of immunoadsorption in the ICU setting, and what do you have in mind regarding this?
Okay, vielen Dank. Thank you very much for this question. Actually, we do have our severe cases, especially we suspect that the patient is under the inflammatory storm. We using CRRT try to help to isolate these inflammatory factors. Up to now, as I know, we do not summarize the result or see the benefit, but theoretically it should be helpful. We're using in several severe cases CRRT. We sent 42,000 people to there. This medical personnel, they have different experience, different level from different cities. The whole China, we send our teams from a different hospital, and the regimen is also different. This is why the Ministry of Health, they published 7 editions of the guidance or guidelines for the diagnosis and the treatment, how to handle the COVID-19. And only now, recently, in the late phase, we are really standardized the whole therapeutics. Mm-hmm. But we do not have a lot of experience using the CRRT of this very critically ill patient.
Thank you. A question which was posed by Dr. Baer and by Ms. Al-Oshari is, what do you expect? What's the prognosis for the patients in China and for the population in China? Do you have ideas for a second wave in mind, which is connected to, do you think about immunity regarding COVID-19?
I don't believe this the public immunity will happen, because you never touch this virus. This is why I think this virus affect all the population, no matter old, young, and no matter man or women, and no one gets immunity for this. No one has immunity against this virus, and this is why we have to really protect ourselves. But through this very strict control of our patient and also strict protection of all the population, we have since about 2 weeks in whole, except the middle part of China, Wuhan, zero infection. And yesterday I just checked, we have 55 cases. 54 was from either England, from Italy, and all the students, they are back. They get found positive by the airport. And one is we call related cases. This patient, he has close contact with the student, this family member, and get infected. We have yesterday only 55 cases. Actually, otherwise, without the imported cases, we have since 2 weeks at zero. If we do not control, this is why we have all the passengers who came, no matter from, especially the severely affected area, with 2 weeks isolation. We put all the passengers after landing in the hotel to observe, no matter who, for 2 weeks. And after 2 weeks, we're using the swabs to test the nucleic acid with negative, no fever in the 2 weeks, okay, and the passenger get free. I think this is very important. You have to really to convince the people, the community, that really protect everyone, because no one had a community against this.
Which will create challenges in future when all these restrictions will be undone. What are your thoughts? Do you have personal experience regarding specific therapies with chloroquine or immunosuppressions, or?
We use this, but we are not very sure. But we use it for every patient. This immune therapy using the cortisone only for the patient with fulminant myocarditis, and, for example, we have the evidence of severely inflammatory storm, because this cortisone will really prolong the course, and also maybe leading to subsequent bacterial infection. You should be very careful. We do not use in every patient.
So yesterday we had a talk about cardiovascular risk factors. So we learned that diabetes and hypertension are risk factors for a severe patient course. Is there anything you found that this would strike you? You wouldn't have imagined that before, that which is very special about these patients.
Yeah, that's self-sufficiency, I believe, because the patient has the respiratory failure. If you are conflicted with diabetes, the chronic disease of coronary artery disease, hypertension, and so on, I think, of course, the late outcome is worse. As I explained, the hypoxemia will affect every organ. If you have, for example, conflicted with ischemic heart disease, especially coronary artery disease, of course, the outcome is worse.
And is there, and we saw, the question is by Ms. Zastavna, a male 40-year-old person with diabetes mellitus type 1 without secondary diseases, with a good diabetes. Do you think that this person, well-managed diabetes, do you think that this person has a higher risk for severe patient course with COVID-19?
To this specific case, I'm not very sure how to explain. It might be not, because what we do see, especially the middle age, younger age patient, the today is still very okay. Suddenly, this case get worse and get ventilated and died, because we do not know what is the key becoming worse. I think we have to really monitor the risk factors, inflammatory factors. The patient they died have the exploding higher CRP and all the inflammatory factors. I think if you are in this situation, you are suddenly in a high risk. Otherwise, maybe not.
Hello, Professor Piske.
Hey, hey,
hello,
David. Hey, Junbo.
Hello.
Good to
Thanks for
see you
joining
and
us.
hear you. And again, thank you very much from our side here in Germany and in Berlin at the DZHK for this great interview and these important informations that you gave us and are still giving us.
Gerne.
So, in patients with a severe course of myocarditis, this is one question from Ms. Anshari. So we talked about changing from VV to VA mode in ECMO. Is there anything else in your management what you would change?
Yeah, for this special, for example, we call fulminant myocarditis. I think the handling is something different. You have to really early use ECMO. I think better is VA mode or VV or VA mode because in the fulminant myocarditis, the ejection fraction is suddenly lowered to about 20%, something even lower. And if you see the echo, the heart will not move. That's very importantly, you use a VA mode, especially I think to protect the heart function or to improve or help. The secondly, I think is very, very important. You have to using the extra large dose of vitamin C. We don't know why, but it will help. Thirdly, I think in this group of patients, you have to using really cortisone to help the patient to recover, to overcome this acute phase, and you can manage the infection caused by the bacteria.
Can I ask here? Did you publish these recommendations? Can we read them somewhere?
We published this first in Chinese. Afterwards, we translated to English. This will be, you can find it in the website of World Heart Federation. But how to using the ECMO, tomorrow I send this to you, and we have the recommendation how to proceed. We could not call guideline consensus. This we publish this in English, and I send it to you tomorrow.
Thank you.
Thank you very much. And one question I have only on a technical base. Did you perform biopsies in patients with COVID and high levels of troponin?
It's not possible because in the ICU, maybe you have seen from the news, it's not possible. It's everywhere protected. We have different groups. It's not possible because the patient is not under X-ray. We do not do any biopsies, but we did some of post-mortem autopsy, and we found that in the first case, actually, we do not find any virus in the myocardium, but we do find the infiltration of these lymph cells. Oh, I forgot. You have in this group of patients, you have really the lymphocytopenia. The lymph cells are lowered, very low, and we find the infiltration of these lymph cells in the myocardium. And in the later autopsies, we in the ICU or CCU, all the medical personnel is totally covered. To manipulate this biopsy is not practical and not possible. Therefore, I do not know anyone doing my biopsy in this kind of patient.
Dr. Schlaps asked, and he thanks you for your insights, and he asked, did you observe an increase in severe courses in patients with allergic conditions like asthma?
We do not analyze this. I can ask because I have still two fellows still now working in the ICU. I will ask. We do not notice this the combination.
Can I ask another question, David?
Bitte.
Junbo, we had a conference call yesterday with our cardiology colleagues in Italy, from Brescia and from Bergamo, Michele Senni and Marco Metra. and they reported that 90% of the hospital capacities are currently occupied by COVID patients, be it on ICUs, on respirators, but also on the regular wards. And of course, we are two weeks behind Italy. And our concern is that we will not have enough capacity to treat our other, emergencies. When the COVID pandemic takes over and also takes over almost all capacity of our hospital beds. So, for example, myocardial infarction, they reported that for for a reason they don't understand, the prevalence and the incidence of acute myocardial infarctions and acute heart failure hospitalizations has largely declined. So they see in their ERs much less myocardial infarctions and so on. And our impression is here now that we have the same phenomenon. How was this in your city?
Okay, Fudan, I think these two questions. One question, I think you have really, you write to for medical, you have to be prepared. This is very important because we have, for example, 80,000 patients all hospitalized. And if the patient hospitalized, the mortality is decreased. If not, and the later outcome is worse, you have to be prepared. This is, I think, very important. Secondly, as I just mentioned at the beginning, you have really advised people to protect yourself using the face mask. If the patient do not get infected, you do not have such a huge population of patients. This is important. Otherwise, you are, I think, the same as Italy, because we do not have any immunity against this virus. Your last question regarding this, we are now doing our statistics. Normally, we have one consensus for the chest pain center in China, and we have, each day, for example, at least our hospital, every morning they report to me, we have yesterday evening 3 or 4 or 5 patients with myocardial infarction. But during this epidemic, we do see less patients. We do not know why. It's because the patients, they are stay at home, or because of less myocardial infarction. The situation, yes, but we now on the national basis, we try to do the statistical analysis to see what would happen. Because of the patient, they are afraid of the hospital infection, they stay at home, or because of what? You are right. It is the situation exists.
Very interesting, yeah. And can I add a question that concerned me? I mean, I think we learned from you and from the way you handled it, and also maybe from mistakes you make, and you can help us to avoid these mistakes. And we learn from Italy now, and others will learn from us. So protection of our staff, I think, is critical, as you pointed out. And self-protection of everybody is very critical. And I think we also in Germany have to get better here. I was concerned about the climatization, where you reported on your results and observations you had in the cath lab, for example. And you switched the AC equipments down. Did I understand that correctly? You shut them off?
Yes. If you want to do catheterization, you have to shut down the central air condition. Otherwise, the whole system will get infected. As I mentioned, maybe you did not get. We did a test. We're using the swab in the ICU, 3 hours. You just test. You can find the virus on it. Because in the ICU, the whole air will fill with the virus.
So did you switch off AC in the ICUs, in the COVID ICUs?
No, we have the negative pressure ICU. All the patients, they are we admit the COVID-19 patient all with negative pressure, no exception.
Okay.
Otherwise, we do not add them in.
If you have that not, you have to switch it off.
I think yes.
Mm-hmm. Okay.
I would ask the last two questions from the online communities. So one is from Mr. Niendorf and Mr. Friedrich, who ask, why do you think healthcare systems are so overwhelmed with COVID-19? Is it the combination of rapid spreading and frequent need for ventilation?
The second question, I did not quite get your question. At the first, I think the widespread is because you do not get protected. You get the people commonly gather too near, and this, for example, for 1 meter, 1 and 2, 1.2 meter, where you have to keep distance. Otherwise, I think you cannot avoid the either cough or the speech or the aerial to conduct the virus transmission. The second question was what that?
And why do you think the healthcare systems are so overwhelmed?
Oh,
I don't know if you have the experience yourself. This is something we see here sometimes.
I did not quite get you. What do you mean by the health system?
So I think what the colleagues mean. Why so many patients have to be hospitalized? Yeah, I think this.
No. Okay. Actually, by this virus, infected patient, 80% they are mild cases. They are not need to get hospitalized, get admitted. But the other 20% really they need to get really ventilated or get the oxygen, because the severe, or we call it 2 steps, severe and critical severe ill. But these 2 group of patients, they need really the help for the ventilator. The normal, the other 80%, it's not necessary, but they have the capacity to transmit.
Do you have a program to observe the recovered patients in order to investigate long-term development regarding CVDs?
Yes, and we now initiated a study, and this is also registered on clinical trials. We try to observe the patient after the recovery, how the effect on cardiac function and lung function, for example. Secondly, you mean the process of the patient. We have to really monitor the patient using the swabs and also antibody till the antibody get positive and the swabs get nucleic acid twice get negative, and we can discharge the patient to area for another 2 weeks, and the patient can be get free. And secondly, I think we do not know the consequences of this this disease, if it would lead into the lung fibrosis and so on. I think we need a long-term observe to see this. But by the CT image, you will by the discharged patient, you will see really the infiltration, and you see the ground glass phenomenon disappear.
Before my closing remarks, Professor Piske, what questions do you have still in mind?
I still have so many questions, but I think it is in the middle of the night in Shanghai now, and I think we should allow Professor Guido to go to bed and get some rest. He has probably a heavily loaded working day tomorrow. For me, it was an extremely important interview, and again my thanks to Junbo and also David to initiate this and lead such a great interview, and I hope we can maybe, as we proceed here in Germany with the situation, maybe we can get in touch for a second time in 2 weeks or whenever.
Anytime, I'm be happy to be of help. Actually, this afternoon, I just sent some masks, the N95 masks to Dresden. The colleague Dr. Praxis sagte, there is really need this mask. I send a small package. You know, for the big package, normally we get stuck in the custom. And exactly. I sent him each package 100 as such a package. I said, if any help I can do, really, I would love to. You know, I was trained in Germany, and Raymond Professor Eber said, okay, should we pay you? I said, you have already paid enough to me because I learned from you, and it's really time for me to really do something. Anything I can do, I would love to. And I would love, will send my this consensus regarding the transplant center and how to implant the ECMO in the COVID-19 patient to you and to Dr. Hashmi, and you put it forward to Hepiska and to all the other colleagues. If any help I can do, I would love to do.
I'm happy.
Thank you so much.
Dear Professor G, thank you very much for your time. It's an honor for us to have you and to learn from you. We appreciate not only your work, but all of the other Chinese physicians who not only treated patients during the last weeks and months, but also published their knowledge, and so we can learn and we can improve our healthcare. Thank you very much.
Okay, thank you. Bye-bye.
Bye-bye.